Jim's slide that he showed you earlier that basically provides an outline of the different entities within NCTN, particularly the restructuring of the cooperative groups. But what I want to really emphasize is what's at the top of the slide, because these are the extramural and advisory committees that are participating and where the prioritization is actually going on. One of them, of course, is the standing steering committees that are involved in helping to prioritize with interacting with the actual groups. And the other is the working group that has been set up as a CTAC subcommittee. If we look at the CTAC structure, currently there are 3 committees. CTAC is the standing committee that was established in 2006, headed by Jim Abruzzi, and which has really established the outline for the clinical trial system. Again, responding to the earlier clinical trials working group that was held in 2005 that recommended changes in the cooperative group structure. There are 2 other committees shown in blue. One of them is a subcommittee of CTAC headed by Joel Tepper. This subcommittee actually is charged with helping to develop a fully integrated clinical trial system, and in addition to dealing with cooperative group trials, also is involved in looking at NCI early phase trials. Again, as I mentioned, Joel chairs this committee and is assisted by 5 other members, including Jim Abruzzi, who chairs the parent committee. The recommendation was made to create an NCTN working group to assist in the evaluation. And as George mentioned, the 2 of us were asked to chair this new committee. And joining us on this committee are 28 extramural members that come from key stakeholder groups. And it's worth mentioning that these groups include the various cooperative group chairs, and we have several representatives. Monica's actually one of the members, as is Bob Comas and Wally Kern, all who are here today. We have a number of cooperative group statisticians, CCOP members, cancer control investigators, a few cancer center directors, myself included, Wally Kern holding actually the role as cancer center director and group chair. We have steering committee chairs, advocates, translational scientists, and then to again have structure across the 3 committees, we also have CTAC subcommittee members like George Weiner, who actually holds 3 roles, not only being on the CTAC strategic planning subcommittee, but also being a lymphoma spore head and also a cancer center director. And then, of course, we're joined by NCI leadership as well. Now, NCTN's working group has been given 4 major tasks. Jim referred to this briefly earlier, again, to basically assess more or less after the fact, after studies that have already been approved, to assess the strength and balance of the various NCTN clinical trials portfolio. And in assessing this portfolio, a desire to really go through each of the disease groups, and that actually has been our first task, looking at the various disease groups. And then ideally, in our later meetings, which we have not gotten to yet, going across disease groups, looking for comparisons and what we can learn from the various diseases and potentially improve in certain disease entities using the benefits that are learned from others. The second main task is to recommend strategic priorities and directions for NCTN, and that's based on the current trial portfolio, really looking at gaps that may exist in our current protocol structure, evolving clinical needs, and of course, most important, to look at emerging scientific opportunities that exist. Third would be to review and assess the working group evaluation process and results. We've had to develop more or less on the fly a method of evaluating clinical trials with regard to their strengths and weaknesses. So the quality of completed trial outcomes, operational performance of the scientific steering committees is also one of the other goals to comment on, and the efficiency of clinical trial conduct as a whole. Lastly is to provide strategic advice to enhance NCTN clinical trials operations. And this involves looking into the possibility of collaborations and timeliness. Now, there are three groups that currently exist in sort of in the whole business of managing and prioritizing the portfolio. Obviously, the first is with the groups themselves in developing trial concepts and then conducting the trials. The scientific steering committees evaluate and approve the trial concepts that are judged scientifically meritorious and worthy of, again, the expenditure of NCI resources. And the working group, again, as I mentioned, is to really, after the fact, after the protocols have actually been in place, to assess the strength and balance of the active trial portfolio and to ideally recommend improvements that could be made to the strategic planning subcommittee of CTAC. Lastly, there's this hope that there would exist a continuous collaboration and feedback through CTAC, which is perhaps best illustrated on this slide. Again, starting with the groups listed on the bottom that I just referred to, the networks developing the individual cooperative groups, developing the trial concepts, the steering committees approving the trial concepts, and then the strategic planning working group basically helping to assess the strength and balance of the active trial portfolio. CTAC as a whole is meant to be interactive with these three entities to recommend potential improvements that could occur by providing feedback certainly to the steering committees and overall making other recommendations with regard to emerging scientific opportunities, the potential for innovative trial design opportunities. Again, as I mentioned before, the gaps that may exist within any disease area, high priority clinical needs, and trials that need to be reevaluated. Well, I want to talk specifically about what we've had an opportunity to do thus far. We've actually had 2 meetings thus far and actually have gotten only through the first 2 of these tasks that the working group has been given. Our first meeting was in July of this year. And I have to say, as I mentioned before, we developed a lot of this on the fly. And one of the first tasks we had after we met as a group was to come up with a method to assess the strength and balance of the trials. And we came up with a rudimentary metric for judging superlative trials, potentially weak trials, and those that fell somewhere in the middle. And we started utilizing colorectal cancer as our first disease that we evaluated during that July meeting and completed an evaluation of all the colorectal clinical trials in the active portfolio. And I want to emphasize also here that we only looked at trials that were approved by the steering committee. We did not look at those trials that met with disapproval during the evaluation process. We had more than enough to do just reviewing active trials. I think we were able to conclude that it was possible to review individual trials within a disease. We gradually refined the criteria for evaluating trials, again, as I mentioned, on the fly. Recommended assigning a single score an overall score that was based on individual trial evaluation criteria. And I think after this concluded that the method that was used for presentation and discussion, where the presentation of the individual disease entity was presented by a CTEP medical officer and the steering committee chair, after which we had discussion and an overall evaluation was made in terms of scoring for understanding the trials, but really as a basis for the steering committee. Again, not looking so much to be judgmental in terms of scoring the individual trials in the disease groups, but looking at this overall as a potential learning exercise. One of the facts that came out during our first meeting in terms of deliberating colorectal trials was the desire to really have more information on ongoing trials outside of NCTN, particularly those that might be done by pharma or those that were being done by international groups as well. Recommendation was made at that meeting also to develop a subgroup within the working group so that in subsequent meetings we would actually have a subgroup review the individual diseases and present, somewhat like a study section might review grants before an actual study section meeting, and help present it to the group as a whole. We've since had an opportunity to evaluate that in our second meeting, which was held this past December, a two-day meeting. I might mention held over the weekend, starting Sunday morning on 8 a.m. and continuing through Monday till noon, really speaking to the interest of and dedication of the group of investigators that participated. And even though we had a very diverse group with a number of groups representing different agendas, different areas of importance to their members, I think we had a very collegial group in terms of assessing and attempting to really figure a working method to evaluate these individual diseases. At the December meeting, we actually completed our gastrointestinal disease review, including those tumors outside of the colorectal area. We also evaluated breast cancer protocols in the portfolio, leukemia protocols, lymphoma protocols, and genitourinary protocols. And I want to emphasize again, I'm not here today to give any definitive remarks about what our decisions have been thus far. We really are still in the process of doing this. We haven't completed the individual disease evaluation, so any comments I make should be taken as interim comments. I also want to emphasize that we have not attempted to relitigate or to be judgmental or pejorative on any of the previously approved studies. This is a learning exercise the way we viewed it, and again, hoping that as a result of this, we could provide guidance for improving clinical trials in the future. And the last point is one that I think is worth noting, and that is that this is perhaps the first time that NCI or any external group to NCI has had an opportunity to look at the whole portfolio. Individual trials are looked at during the approval process, but the ability to sort of digest and assimilate the whole disease group and then hopefully also to make comments across the disease entities has never really occurred in the history of the cooperative group program or clinical trials program of NCI. Now, I think if you'll allow me, again, at a very high level and only at an interim comment, I do think that after going through 5 disease groups, we can say that we've come to, at least at a 50,000-foot level, some comments that we can make with regard to the trials as a whole. The first is that there appears to be a considerable variability with regard to strengths and weaknesses among the individual disease groups, without going into any of the defects, which is not the purpose of this talk today. And as I mentioned, we haven't completed our review of the single disease within disease categories. So it would be far premature to make a comment on any individual strengths or weaknesses. But there are several factors, I think, that come out, and some of these are obvious to anyone that's involved in clinical oncology trials. One is the fact that in some disease groups, obviously, there are more opportunities available to ask great questions with multiple therapeutic agents available to actually propose studies, while others obviously have few active agents that are exciting. There are also differences in terms of the scientific advances. Some of the maturity within the molecular studies that have come out of certain diseases, really focusing on genomic and other biomarkers, identification of specific pathways, and other correlative science opportunities perhaps account for the variability that seems to exist in terms of strengths and weaknesses. But there's still other possibilities that may exist and that perhaps have been suggested by some of us as we've looked at the various disease portfolios. There is perhaps a benefit that could be obtained from having a standard format from NCI in the preparation and submission of individual concepts. There also appears to be a difference that we were able to appreciate in the presentations by the individual disease-specific scientific committees in terms of such that perhaps some guidance to these committees in terms of their overall function might be helpful. I will take the liberty of just looking at one particular disease, and that was breast cancer, because I think overall our group perceived the breast cancer trials for the most part as being relatively strong. Not to say that there were others that were not strong or others that were very weak, but this was one that we felt was relatively strong. It addressed several important questions. We felt it was multidisciplinary, and there was a good balance between both systemic and versus local regional studies. But I think one of the points that came out of our evaluation over the first two meetings is perhaps the need for smaller, more nimble, randomized phase 2 studies looking at newer approaches, and particularly taking into account molecular-driven trials, marker validation, correlative studies, studies that look at limiting toxicity, quality of life, and survivorship studies. Another aspect that perhaps the breast committee might have benefited from would be really utilizing in the concept selection standards to improve trial design. And this could involve perhaps using other groups such as the task forces, working groups, or clinical trial planning meetings to help in the guidance of future protocol studies. I think overall we've come to the conclusion that there are a number of criteria thus far, at least in our two-meeting evaluation over 3 days, that there are about 5 separate criteria that we felt are very important. One is the appreciation of accrual difficulty. It was disappointing, let's say, to look at some disease areas where there was great accrual in certain studies, but very poor accrual in other studies. This obviously is not a good use of NCI funding or time, and it's important to be able to get clarity so that we can perhaps evaluate upfront the feasibility of studies better. Secondly is the clinical importance. It's the importance of study questions relative to the state of the science of the disease. Benefit per patient and for population. George came up with the concept of life years earned or saved. Life years earned, I'm getting into the business area, but life years saved in terms of really having a metric at least for having a possible evaluation of the benefit to the patient or the population. Also the benefit in light of disease context. Scientific contribution, the opportunity here to really test important scientific concepts or proof of principle in the clinical trial setting must be emphasized, as is the importance of integrated correlative study questions. Again, the relative cost and resources, the total number of patients that are required to come up with a conclusion, the length of study, again, both focusing on accrual and follow-up. And lastly, the whole aspect of the appropriateness for the NCTN program. We are currently anticipate there are at least 3 additional meetings that are needed for us to complete our evaluation of the strength and balance of the active phase 3 and large phase 2 studies. Again, we've had 2 meetings thus far. We have 1 more meeting that we hope will be able to finish the within disease portfolio that remains. Following that next meeting, we hope that we will be able to go into the cross-disease portfolio evaluation that we feel will be very important in terms of really how we can learn across diseases to improve clinical trials in the future. But with that, I'll stop. Thank you.